Good morning, everyone. I'm Eric McDonald, the County of San Diego's Chief Medical Officer. We're here today to discuss COVID-19 medical and health misinformation. I'm very pleased this morning to be joined by 4 local medical experts for this discussion, and I'd like to introduce them now. They are Dr. Omid Bakhtar from Sharp Healthcare. He is a board-certified pathologist who serves as the medical director of the outreach laboratory for Sharp Healthcare and is one of the medical directors of the COVID testing lab at Sharp. He sits on the highly infectious disease advisory panel at Sharp Healthcare, and he's also one of the tri-chairs of the county testing task force and is on the state testing task force as a contributor. Also with us this morning is Dr. Cynthia Jamke Bannerman. She is a board-certified OBGYN and maternal fetal medicine high-risk pregnancy specialist at UC San Diego, where she's also professor and chair of the Department of Obstetrics, Gynecology, and Reproductive Sciences. Dr. Jamke published many of the first observations on COVID in pregnancy in the United States while she was on faculty at Columbia University in New York City, and I just learned she just arrived in San Diego this summer, so welcome to San Diego. And she's also a member of the National COVID Task Force for the Society for Maternal Fetal Medicine. Dr. Christian Ramers is here with us this morning. He's the Chief of Population Health and the Director of Graduate Medical Education at the Family Health Centers of San Diego. He's board certified in internal medicine, infectious diseases, and addiction medicine, and holds faculty appointments at UC San Diego School of Medicine and UCSD's School of Global Public Health. He is on the county's clinical advisory committee and equity task forces. He's a member of the National IDSA CDC clinical call escalation volunteer group that responds to questions from clinicians throughout the country when they have questions about COVID. And Dr. Ramers also helped lead Family Health Centers of San Diego's COVID-19 monoclonal infusion clinic sites, and we'll talk about that later. And our 4th local expert is Dr. Mark Sawyer with Rady Children's Hospital. He's a board-certified pediatric infectious disease physician on the faculty at UC San Diego. And he's served on the CDC's advisory committee for immunization practices, and he currently serves on the Western States Scientific Safety Review Work Group on vaccines. Our focus today is the Tuesday, October 5th COVID-19 update that was presented to the County Board of Supervisors. While the discussion at yesterday's meeting was broad, we're going to focus exclusively, as requested by the Board of Supervisors, on misinformation related to health and medical issues. I'd like to mention before we start that the county has established a link on our long-standing COVID-19 website, which is coronavirus-sd.com, that is meant to assist the public in evaluating information on COVID. If you go to that website, you'll see a banner marked Evaluating COVID-19 Information, and by clicking there, you can learn more about different types of incorrect information. There are links on the website to credible sources of information. There are some false claims that have been paired with facts, and there are some frequently asked questions. When we're done here this morning, this session will be posted on the website, and we will update the website as needed with any issues that we aren't able to get to in our time this morning. So with that introduction, I'd actually like to start with Dr. Sawyer, who gave a really nice presentation at yesterday's meeting. Dr. Sawyer, you really spoke to the efficacy of the vaccine, that is how well it works, and the risks of COVID infection. And you also commented on the different systems that are in place in the United States to monitor vaccine safety. And I wonder if you could briefly summarize what you presented yesterday, since it directly addressed some of the comments given by the public.
Sure, happy to do it, Dr. McDonald. I'm going to actually share a few of the slides that I showed yesterday to illustrate the points. I hope you're seeing my screen now. So I just want to start off with saying that vaccines can do different things. They can prevent infection outright. They can prevent you from getting sick. They can prevent you from getting in the hospital, and they can prevent you from dying. And those are all different measures of effectiveness. So when people say the vaccine isn't working, it is correct that it's not working as well as it used to at preventing infection. That is, people who are immunized may get COVID, but they're getting very mild disease. They're not ending up in the hospital. In fact, almost everybody who's hospitalized now with COVID are unimmunized people. The vaccinated people are being protected. And here's some actual numbers that illustrate what I just said. This is national data from CDC. Each of these colored lines is a different study, which shows in the last few months over the summer, we are seeing some decreased effectiveness of vaccine against preventing infection, but not complete decrease. It's still preventing infection in the majority of people, but not as well as it used to. In contrast, this is another set of studies looking at hospitalization. And although you can make an argument there's a tiny decrease in July, basically the vaccine is still keeping people out of the hospital. And in fact, in San Diego, at our most recent peak at the end of August, early September, people were 46 times more likely to be in the hospital if they're unimmunized than if they were immunized. So to say the vaccine does not work is just incorrect. We've been talking a lot about the Delta variant this summer, and that is part of the reason the vaccine is not working quite as well. But here's also some CDC data from the IB network, which is a group that's specifically looking at this question, comparing the effectiveness of the vaccine at preventing hospitalization in the pre-Delta era compared to this summer, where Delta took over in the United States and in fact much of the world. And it's looking at different risk groups, but the point is, if you compare the numbers across this chart, there's only a very slight, and in fact not even statistically measurable, decrease in the rate of hospitalization pre-Delta compared to Delta era, which is now. So the vaccine is still working and it's keeping people out of the hospital. Now I want to focus on side effects because that's what has people the most concerned, and the claim is made that the vaccine is hurting more people than it's helping. The first thing I want to point out is that these are a series of systems that are in place in the United States to specifically study vaccine safety. The first one, though, is one that people frequently misuse and misquote, the Vaccine Adverse Event Reporting System, or VAERS. This is a system that's been in place for years in the United States. It allows anybody, a patient, a doctor, a relative, to report a potential side effect from a vaccine, which is usually identified because sometime after the vaccination, something happened. But that does not say that the vaccine caused whatever happened. That has to be determined through review of the medical record. And that does not happen in the VAERS system. And nobody reports to the VAERS system when nothing happens after the vaccine. So it is a very inaccurate way of determining whether there are side effects from the vaccine. And instead, I would have people focus on the vaccine safety data link, the third system that listed here, which has close to 9 million people in it, which are all part of managed care groups like Kaiser, and they all have electronic health records. So through those electronic health records, you can accurately determine how many people got a vaccine and then how many events of whatever side effect you want to study happened. And you can see if they're clustered right after the vaccine, which would suggest that the vaccine actually caused the side effect. And that is the way to accurately determine vaccine side effects. And we've been using this system for years, in fact, over a decade, and it served us very well. And when you look at that system, this is what you learn. These vaccines have lots of minor side effects. Everyone who's gotten this vaccine knows that. It causes soreness where you got the shot and makes you fatigued sometimes. It may even give you fever or headache or joint pain. So yes, the vaccine has side effects, but the side effects are minor. They go away in a couple of days. There are severe side effects, and we know what those are now. So people who say we don't know what side effects this vaccine causes, or the vaccine hasn't been studied enough, are not taking into account that we have given these vaccines to over 200 million people in the United States. And in fact, if you look worldwide at all of the COVID vaccines that are out there, there have been over 6 billion with a B, people immunized with COVID vaccines. So we know exactly what the serious side effects are because we've given enough doses that we can measure that. And these are what the serious side effects are. And they're serious, no doubt. Anaphylaxis, thrombosis, clotting, blood clotting, Guillain-Barré syndrome, which is a neurologic condition that happens after some vaccines. And what's been publicized the most, myocarditis, which is inflammation of the heart. And I put those numbers on there to show how often those happen. But to summarize the impact, the negative impact of the vaccine, somewhere between hundreds and thousands of hospitalizations and deaths have been prevented by using the vaccine for every single case of these serious side effects. So you are much better off getting the vaccine than not, even considering these serious side effects. So I think I'll stop sharing my slides there and take on any other questions that you would like to bring up. I'm not hearing you. Is that me or is that you?
Nope, that's me. I just had to unmute myself. Thanks for that recap. And, the public speakers yesterday were stating that vaccines were hurting people more than the virus, and that just simply isn't true. But specifically, this claim was made about children, that the risk of the vaccine to kids is greater than the risk of getting COVID-19. I wonder if you can comment about what you're seeing at Rady's and the cases of significant COVID-related illness that you've seen there.
Yeah, we've had something like 100 kids in the intensive care unit at Rady Children's Hospital just here in San Diego. Across the United States, there have been over 400 deaths in children from COVID. So to say that it doesn't cause serious illness is also not correct. It causes more deaths than we see every year typically from influenza. Now, having said that, we have seen some of the side effects, the serious side effects in children as well. We have seen myocarditis in teenagers who have gotten the vaccine, but the cases have all been mild. They've been in the hospital maybe 1 or 2 days. They have recovered and they've had no serious consequences. So fortunately, we haven't had any deaths in San Diego from COVID, but it's only a matter of time. If we keep having, this pandemic continue, we will see deaths in children. So, it is not true that the vaccine causes more injury in children than it does prevent illness. It is a different equation, and that's why the FDA is being very careful to review the data on the vaccine safety in children before it is licensed or released under emergency use authorization. So that meeting is coming up soon, and we'll learn a lot more about the specific data of vaccine safety in children.
You spoke about the vaccine adverse events reporting system, or VAERS. And despite the fact that the VAERS website explicitly states, as you emphasized, causation cannot be determined or inferred based simply on the initial report, some members of the public seem to think otherwise. I wonder if you can comment, though, on why there are more reports in VAERS for the COVID vaccine than for other immunizations like influenza.
Well, part of the reason is we've given more doses in the last year than we have many other vaccines. Some vaccines are only given periodically, and we have, as I said, given over 200 million people have been vaccinated. In addition to that, we're encouraging people to report side effects so that we can learn about it. It's a new vaccine, everybody's talking about it, so it's natural that we're hearing more about potential side effects. Now, I don't want to discount VAERS altogether. It has a very useful purpose. It alerts us that, well, maybe this is a side effect from the vaccine. But then to study that, we have to turn it over to one of those other systems that can scientifically determine whether whatever side effect we're looking at was actually caused by the vaccine.
You know, another myth is that the Pfizer vaccine specifically has not been approved by the FDA. I wonder if you can just address that for me.
Yeah, it's a bit confusing, the FDA process. For many months, the vaccines have been available under what's called emergency use authorization, which is an abbreviated approval process, and it has restrictions placed on it, and that's what we've been using the vaccines under. But just a month or so ago, the FDA did formally approve the Pfizer vaccine down to 16 years of age, just like it does every other vaccine. And I've been part of that process, and I can assure people that the approval process of these vaccines is exactly the same as all other vaccines that I've participated in that committee's deliberations on. The other vaccines are still under emergency use authorization, and when we start using them in young children, they will also be under emergency use authorization. So again, there's restrictions and careful ongoing surveillance to make sure that there aren't unexpected side effects when we start using a vaccine. But the Pfizer vaccine is approved for adults.
And one last question for you, Mark. You know, there were some concerns raised about the way we present statistics in the county, comparing people who are fully vaccinated versus those that are not fully vaccinated. And you know, we determined that people are fully vaccinated 2 weeks after they've completed the series that they were given, either the 2-shot vaccine or the 1-shot J&J vaccine. You know, why do we use that cutoff of 2 weeks after you've completed your series to talk about the difference between people who are vaccinated versus fully unvaccinated?
Yeah, that's a very standard cutoff that's used for all vaccines. And the reason is it takes about 2 weeks for your immune response to react to the vaccine. So the first day after you're immunized, you're no better off than you were before you were immunized. But within those 2 weeks, your immune system responds to the vaccine and ramps up the immunity so that you're protected. So the mRNA vaccines are 2-dose vaccines. So you need to get both doses to get full protection. And we wait 2 weeks after the second dose to say, okay, you should be good to go. And that's what we measure.
Yeah, thanks. I think a lot of people think, hey, I got my shot today, now I can do whatever I want. And you really need to wait till your immune system, in fact, kicks in and responds to the vaccine that you've been given. Well, thanks, Dr. Sawyer. I'd like to turn next to Dr. Bakhtar. There weren't many comments at yesterday's meeting related to testing specifically, but questions about tests that are used to diagnose COVID-19 have been raised in prior meetings. And first, I'd like to ask if you could explain, you know, what the two major types of tests are that are used to diagnose COVID-19, the antigen test and the nucleic acid amplification tests.
Good morning. Thank you, Dr. McDonald. Happy to be here today. So that question sort of requires us to step back a little bit and just maybe picture in maybe a cartoon world kind of a way what a virus looks like. And if you were to just imagine that a virus has an outside coating that's made of protein, and then on the inner portions of the virus, there's what we call nucleic acid, or really the genetic material that's responsible for the information that makes the structure of the protein. In that image, it's a little bit easier to understand how these tests are devised. So there are, as you pointed out, a couple of different types of diagnostic tests. Those include antigen tests and nucleic acid-based tests. And really the antigen tests detect those protein structures that I was discussing that make up the actual body, if you will, of the virus. That's a very different test than the nucleic acid test, which includes the polymerase chain reaction, or PCR test, that you may have heard about, widely sort of publicized as probably the main diagnostic test for COVID. Now, those nucleic acid tests actually look for and amplify that genetic material that's inside of the virus, whether it be COVID or many other viruses or infectious disease type tests that we have. And they amplify that. And by amplifying it, you can then detect the presence of that nucleic acid, which is a pretty good surrogate for showing that that virus is actually present in the patient.
You know, a misconception that's been raised in prior board meetings is that the PCR tests that you referred to have been recalled by the CDC. People have stated that at our meetings. I wonder if you can speak to that.
Yeah, I mean, I think it's important for people to understand that there is no one PCR test, and there is no single authorization for a PCR test or all PCR tests. In fact, like many tests that are on the market, there are many types and manufacturers of PCR tests or antigen tests for that matter. All of them have to go through a regulatory authorization process that Dr. Sawyer was alluding to. But I think this misconception or misinformation probably comes from the fact that the CDC was the first entity to provide a test in the United States. So early in the pandemic, there was no diagnostic test that was available in the United States, and the CDC was very active in creating that test. That test, like any other test, was authorized by the FDA, and the CDC is not really in the business of creating tests that are to be widely used in sort of a general setting. Instead, this test was really created because we were in a pandemic and there were no tests available. So over time, as frankly, hundreds of tests have now become available, the CDC decided that their test was really no longer necessary as a diagnostic test. And I think it was maybe the mid portion of this year, they put out a statement saying that they would be pulling their test, again, largely because they're not in the business of providing tests to general laboratories in the United States. So I think the misconception that's out there is that the FDA pulled the test. That's a false statement. The CDC is choosing no longer to maintain the test. The other misconception is that the FDA pulled the test because of how well the test or how poorly the test was performing, and that is an absolutely false statement. That is just not true. So again, really, in conclusion, we shouldn't extrapolate the single test that CDC has chosen no longer to maintain to be a blanket statement about FDA authorized tests. There are hundreds of FDA authorized tests that are out there. The vast majority of them continue to be used. It is a true statement that there are tests that FDA has decided or the manufacturer has decided to pull back for performance reasons. That's not a bad thing. That's a great thing. The fact that we continue to have oversight of these tests and as part of the emergency authorization process, continue to maintain these tests and pull them off of the market if they are not performing in the way intended is exactly what we want. So I hope that answers the sort of the misconception that's out there.
Well, I think it does. You know, another claim is that different cutoff values for the PCR tests are used to determine whether a test is positive depending on the vaccine status of the patient. And I just wonder if you can just address that as because that's a claim that's been made.
Yeah, no, that again is a false claim. Again, these tests undergo rigorous analysis before they're ever submitted for authorization to the FDA, and then again there's analysis after that. The entire process requires that such cutoffs be submitted to the FDA for detection of virus. So that's a proprietary thing that happens when that data is sent to the FDA. So that cutoff value is largely determined by the manufacturer, and it has nothing to do with whether the patient is vaccinated or not. Now, that cutoff value may vary from one test to another, depending on what that manufacturer decided to use, but it's not a separate cutoff for the type of patient, specifically vaccinated versus not.
No, I think that's important to emphasize. It's the platform and the manufacturer that determines what the cutoff is, and not the nature of the sample that's being submitted to be used on that platform. So I think
that's exactly correct. Yes.
Another issue that came up is about false positive tests that came up yesterday. There is the claim that the most recent surge in cases is just due to testing. And that's despite the fact that hospitalizations and deaths rose with this reported surge, and that the percentage of tests that were positive actually went up, even though the same tests were being used. The good news is that's been coming down recently over the last few weeks. But I just wanted to ask you about how common are false positive tests, and just really address this issue. Can false positives explain the most recent surge?
Well, I think actually, Dr. McDonald, you just probably answered the question. When you have an endpoint of disease, significant disease, hospitalizations, and death, it's hard to argue that those are false positives, because by definition, they're not. The patients died from the disease or had disease that was significant enough where they were admitted to the hospital. Now, as with any test, you ask any pathologist, any medical director of a laboratory, there are always false positives and there are always false negatives to every single test. We strive to make tests that have relatively low proportions of false positives and false negative tests. And that's what we did with these COVID tests. And most of them perform incredibly well, especially in the hands of trained individuals, especially when we are selecting for the appropriate people to test or for how often to test. But the notion that this spike is because of false positive results is just incorrect for a couple of reasons. The main one being what you already stated. There are sick people and there are people dying. So it's hard to deny that. Secondly, I can tell you, just over the course of the last 18 months, we're able to do additional testing and see, what types, which ones of the positives or negative tests are potentially false positives and false negatives. And again, compared to the scope of the disease, the number of people that are getting ill, the number of false positives and false negative tests are far too small to account for the scope of the current disease. Moreover, we're in an era where we can actually sequence these viruses, and we can subtype these viruses. So, and all of that data is publicly available. There are actually multiple websites that do that. And in looking at that data, you can actually see the transition of the virus from one type or another. So for instance, if you go back to maybe the month of May, you'll find that what we called alpha was about 60% of the cases in San Diego County, and Delta was less than 5% of the cases. We now have Delta representing 99.8% of the cases in San Diego. So if the concept was true that these were false positive results that were occurring because, for instance, patients were having remnant genetic material that was being picked up in the testing, then this data would show that that's absolutely untrue, because we actually saw a transition from one type of virus to another. And if this were old remnant DNA, we actually would be able to pick up on that in our sequencing data. Moreover, just to add one more point to this, we sequence, at least at Sharp Healthcare, we sequence 100% of our positives. And the cases where you have sort of remnant nucleic acid that may have been from a prior infection that would lead to what would be deemed a false positive. Oftentimes those don't sequence well at all. And you need to have a sort of a threshold amount of nucleic acid to have those cases get sequenced. And so again, we have yet another measure to show that those likely are not false positive tests.
I really appreciate you bringing that whole genome sequencing issue up, because that is something we use on the epidemiology side. We're often able to connect the dots between cases because of the relatedness by whole genome sequencing between the viruses that are detected. In fact, there's a natural evolution to these viruses, and you can sort of follow them over time as they go from patient to patient. You can see what's happening to the virus, and you can sometimes see that they're identical in certain patients, but you can also see that the relatedness over time. And that kind of addresses another false comment that was made in yesterday's meeting, that it's vaccinations that are causing the mutations. That's not true. It's the natural evolution of the virus, that it goes from one host to another in the community. So thank you for that. And we could spend a lot of time talking about laboratory stuff, but actually I'd like to turn now to Dr. Jamfi. Again, welcome to San Diego, and thanks for being on this panel. You know, given the recent CDC advisory that emphasized the need for pregnant women to get vaccinated, can you let us know why it's important for women who are pregnant and those who wish to become pregnant to get vaccinated?
Hi, first of all, thank you for the warm welcome to San Diego. It's such a pleasure to be here. I actually have a couple of slides that might help answer some of the questions. So I think I'm going to, if that's okay, just go ahead and share my screen and go through those.
Oh, that would be great. Thanks.
Perfect. Let me. All right. Hope you all are seeing that. Okay. Perfect. All right. So these are just a few slides really to kind of focus in on why it's so incredibly important right now for pregnant people and those who are considering pregnancy to get vaccinated. Let's see. Okay, perfect. So the most important piece to understand from this particular slide is that if you are pregnant and you get COVID, you are more likely to get very sick compared to someone who is not pregnant, who also gets COVID. So this slide shows that ICU admission, ventilation rates, ECMO, and death are more common in pregnant people compared to non-pregnant people who similarly get COVID. And this is in fact some of the data that evidenced why the CDC has listed pregnancy in and of itself as a high-risk condition for the disease. We now have ample data on the safety of the COVID vaccine in pregnancy, and we have been talking about VSafe and VARS previously in this session, but importantly, as was mentioned, one of the differences with this vaccine was the CDC was eliciting folks to enter their symptoms and enter their information because it was a newer vaccine. And so we were very eager to hear how people were reacting to this. And in that, pregnant people also listed their information. And so the first report that was published in the New England Journal of Medicine basically showed the first kind of 2.5 months worth of data. And what they showed was that the rates of miscarriage, stillbirth, preterm birth, and all of the adverse pregnancy outcomes they looked at were not different if you were vaccinated compared to the historic numbers of what these are expected to be. And since then, we have even larger amounts of data to show that there's absolutely no difference in miscarriage rates, stillbirth rates, or any complications for vaccinated pregnant women compared to people from historic rates. There are so many benefits to COVID vaccination during pregnancy. Here's one study that looked at people who had received the vaccine. So some of them were pregnant, some of them were breastfeeding, and then 16 of them were not pregnant. What they showed was that if you got a vaccine, whether you're pregnant or not, you had the same immune response, which was really important. But it was a better response than having actually had COVID infection. So with COVID infection during pregnancy, you had some antibodies, but not as many antibodies. And antibodies, remember, is what we all want, not as many antibodies as if you were vaccinated. Importantly, the vaccine-generated antibodies were found in the cord blood and the breast milk of pregnant people, meaning that they could actually transfer immunity to their newborns, which is incredibly important. It's actually one of the few things that you can do to protect your newborn from COVID for the first several months of his life. So there's so many recommendations now from all of the organizations that kind of oversee and govern pregnancy and pregnancy-related questions. So ACOG, the American College of OBGYN, strongly recommends that pregnant individuals are vaccinated against COVID-19. The Society for Maternal Fetal Medicine goes on to say that pregnant, postpartum, and lactating people and those considering pregnancy should receive the vaccination, and it's the best way to reduce maternal and fetal complications of SARS-CoV-2 infection. The Society for Reproductive Medicine, so this is the group that oversees fertility and infertility issues, says that vaccination, either pre-conception or early during pregnancy, is really the best way to reduce maternal and fetal complications. And I didn't show this data, but there's another very large study that looked at women who either were just about to become pregnant or in the first 20 weeks of the pregnancy who got COVID vaccination. And again, no adverse events. And these women were followed all the way to the end of their pregnancies. No differences in any complications compared to folks who had never been vaccinated in years prior historically. And then finally, the CDC also now recommends that COVID-19 vaccination is recommended for everyone over age 12, including those who are pregnant, breastfeeding, or trying to become pregnant in the future. So in looking at the CDC data from September 25th, that's the most recent in terms of the vaccination numbers, only 25.6% of pregnant women are vaccinated nationwide. And when you look at just general vaccination rates across the country, this number is incredibly low. The Delta variant is more contagious. And what we all know, and I think can appreciate, is that it's really the unvaccinated that are getting sick. These are the people that we're seeing in our hospitals. So unfortunately, pregnant women are in this unvaccinated group, and they already have a higher risk, as I've shown you, than other folks who also have COVID. So this is a national problem and a national emergency. So I wanted to show you this picture kind of to bring it home. This is a San Diego couple who died of COVID, and they left behind 5 kids, including their newborn. So the pregnant person here, this is a picture of her kind of, I guess in better times. She obviously looks pretty healthy. She was a 37-year-old nurse who got COVID at 32 weeks. Became very sick very quickly, and usually we try not to deliver them because of COVID, but became so sick that she needed to be delivered, so had a preterm infant. But the COVID continued to become worse, and she died a week later, never having met her newborn. She wasn't vaccinated. Around the same time, her husband had contracted COVID as well, and the family was really rooting for him to get better, but then he died 2 weeks later. And so here's this family with 5 kids and no parents. And this is not an isolated story. This is, in fact, what we're seeing. I brought this up because this is a San Diego couple. I also happen to work with someone who knows them very well. And it's really unfortunate that this is the reality, and this could completely have been prevented with vaccination. So in the last week, in fact, exactly a week ago, the CDC issued an urgent alert for pregnant people. The highest number of COVID-19 related deaths that we've seen in a single month occurred in August. 22 pregnant people died. So this, in fact, is killing pregnant women. And there's absolutely no reason that I can think of that a pregnant person should not be vaccinated. Pregnant people have one of the lowest vaccination rates, and we have data to show safety and efficacy. So it's so incredibly important. I think those of us who only specialize in pregnancy and work with pregnant women are disheartened and a little frustrated in knowing that some of these cases that we're seeing really every day could be prevented. And so hopefully we get the message across to all of you. So that's what I have in terms of slides, and I'm happy to answer any other questions that you have, Dr. McDonald.
No, really thank you for that. Really quite sobering story. You know, there were statements made in some of our Board of Supervisors meetings that pregnant women are not at risk for bad outcomes from COVID because they're just young, and young people don't get bad outcomes. And I think you've really demonstrated that that just simply isn't true. And you've had direct experience taking care of these these patients. I wonder if you could make any comments related to your perspective as someone who works with patients with fertility issues, that people have concerns that vaccination in particular might result in some adverse effects on fertility.
So we actually have good data to show that that's not the case. There was a report published from a very busy IVF fertility center in Chicago where they looked at fertility rates for women who had come there for IVF kind of during the course of the pandemic. So some were vaccinated, some weren't vaccinated. And they decided to compare fertility rates in the vaccinated group versus the unvaccinated group. Absolutely no difference in fertility rates in people who are actively undergoing IVF. Similarly, there was a study looking at sperm counts in healthy male volunteers who had their sperm counts done, then got vaccinated, and then had their counts repeated. Again, no difference in their sperm counts. And even anecdotally, when my cousin was undergoing IVF and had the opportunity to get vaccinated, I encouraged her to get vaccinated, and now she's very successfully pregnant and about to deliver. These things are really important, and it's sad that the misinformation out there is kind of so rampant. But yeah, no effects on fertility.
And you really already directly addressed the concern about miscarriages and vaccines. But one of the other concerns that's been brought up about just changes in menstrual cycles related to vaccines. And again, I wonder if you could address that.
Yeah, I think there's some information in the literature about this, which I think might have been a little misleading, because there was a report way before vaccines were ever available for COVID that looked at menstrual cycle rates related to COVID infection and COVID anxiety, and found that the anxiety related to COVID might in fact be altering women's menstrual cycles. This is in an era before there were vaccines. There's no evidence of vaccines in any way altering the menstrual cycle.
Yes, thanks for that. But before I move on to Dr. Ramers, actually, I did want to make a comment about an issue that came up yesterday and at previous COVID updates. Some people have commented that the issue of wellness has not been addressed with respect to COVID, and speakers have highlighted the wellness benefits of proper diet and exercise, as well as the need to stop smoking and vaping. And I just want to say that we completely agree that these are not just important for COVID, but all the leading causes of death in San Diego County. We recently passed our 10-year anniversary for Live Well San Diego. In fact, this is the mask that I use frequently when I'm here going out in places where I feel that I need to be masked. And the central theme for building better health for Live Well San Diego is 3-4-50. That is, that there are 3 behaviors: poor diet, lack of exercise, and smoking, that elevate the risk for 4 chronic diseases: cancer, cardiovascular disease, chronic lower respiratory infection, and diabetes, that together cause more than 50% of the deaths in our county. And some of those conditions, in fact, all 4 of those conditions increased your risk for poor outcomes from COVID. So we actually, I think everyone on this panel would encourage all San Diegans to look at their lifestyles and work on improving their diet, increasing exercises, quitting tobacco and vaping product use. And these are not activities that should replace the activities that you use to reduce your risk from COVID. They really should be complementing them. And for some reason, there are speakers that come to our meetings that try to create a contrast there. There is no contrast. Really, those things work together to protect all of us in the public. So just having addressed that misconception, Dr. Ramers, I wonder if you could address some of the other issues that have come up in our board meetings. Some people just claim that COVID-19 isn't a public health crisis, and that COVID illnesses and deaths are really due to other causes, not from the virus, that causes, not from the virus SARS-CoV-2. And since most cases don't die, it's not really a health emergency. I wonder if you could just address that. I know that's a softball, but I really need to start with that because people just keep making that comment over and over again.
Yeah, thanks, Dr. McDonald, for having me. So I'll first just say that I think the question implies that the books are being cooked in some way. And I can tell you that they simply are not. Having done a lot of international work, we're not, there's other countries that are reporting all of their deaths as well, and there are academicians looking at this, and if anything, the deaths are underreported. So the numbers that we have, over 700,000 people that have died of COVID, surpassing the death rate in the 1918 influenza pandemic. I mean, if this is not a public health emergency, then what is really? The issue of people dying of something else and having COVID on board, many patients that I've had do have comorbidities, obesity and diabetes and heart failure, but they're walking around and doing fine until they get COVID. So certainly people that are stressed, that have an acute respiratory infection like this are more likely to die if they have underlying conditions, but it's certainly the COVID that pushes them over the edge. And having filled out plenty of death certificates, there's no pressure or no incentive to put something on the death certificate that is not legitimately there. And I think that's, physicians are basically, sworn to be truthful in these documents. These are legal documents, and they're not really making this up. Finally, the excess mortality, as I mentioned, people in the Institute for Health Metrics and Evaluation and University of Washington have done analyses of these, and we're probably underestimating by a lot in many of these countries. So many reasons to think it is a public health emergency. And you mentioned that there's many other things other than death. So we're starting to see in our clinics many people with long COVID or post-acute sequela of COVID, as it's called. The biggest surveys that have been done put the point estimate at about 30%, 20 to 30% of people that survive COVID. If you assess them a month or two afterwards, they still have ongoing symptoms. And these are quite concerning: brain fog, where people just cannot think clearly anymore, fatigue, shortness of breath, autonomic instability, which means people's heart rates just kind of go up very fast with no warning. These are debilitating symptoms of people that have survived COVID. We've seen them in children as well. So to say that children are not affected by this is not true either. And many people have thought that the real burden of COVID is going to be in the next 5 years, when all these people are either no longer able to work or their quality of life is profoundly diminished. And we are frankly unprepared for this at this point. With so many millions of infections, if we estimate that 30% of them are going to have long-term effects from COVID, even if they survive, they won't show up in the mortality statistics. We have a big problem on our hands.
Yeah, thanks for addressing that issue, Dr. Reimers, because again, some people like to really only point to death as a bad outcome, but really there are all these other effects which are profoundly affecting people's lives. I have a young relative in my family who got COVID before the vaccine was available and lost his sense of smell, and it's been months and hasn't gotten it back. And it's been incredibly debilitating to him as a young man. I wonder if I could just, again, I'm saving up some questions. You get a little bit of a potpourri of things as opposed to on a central topic, unlike our previous three folks. Some people think that masks don't work to prevent COVID transmission. They're misinformed to think that masks somehow reduce oxygen that's available to someone, or make it difficult to breathe, or build up carbon dioxide in their system. I wonder if you could just address these misconceptions.
Sure. There was confusion at the beginning when we had some public officials saying, please don't go out and buy masks. That was really more to protect the supply, when the supplies of masks were limited for our healthcare workers. And that, of course, is perpetuated. The literature is overwhelmingly in support of masks working. Of course, there are different types of masks, and different types of masks work better. For example, surgical masks and N95 certainly block particles a little bit better than cloth masks. But we know that they work. There's now been a randomized controlled trial that was conducted outside of the US, showing that masks do indeed reduce infections. And the dangers of masks that sometimes are shown on YouTube videos or things like that are just operating on a fundamental misunderstanding of human physiology. When you put a partial pressure monitor of carbon dioxide up to somebody's mouth and they inhale and exhale, you have differences in carbon dioxide. That's just simple biology. Ask any surgeon that wears a mask for 8 to 12 hours. They're not getting carbon dioxide buildup that's impairing their brain function. So the oxygen goes through the mask just fine. The mask does not filter oxygen or carbon dioxide. It filters the droplets and the aerosols that contain the virus. There's also other literature out there and sort of anecdotes about the masks irritating people's faces and causing bacterial infections. And likewise, I would say, hundreds of thousands or millions of healthcare workers are wearing masks, really, and have worn masks for 8 to 12 hours a day, including myself, over the last 2 years. And the vast majority of people don't have allergic or infectious complications of masks. If somebody does, then I would say find a different mask and worry about the hygiene of that particular mask. And then finally, about dental problems or tooth decay, I think that some people have claimed that masks are causing. That's really simply not true. And there's many of other hygiene issues that you can do as countermeasures to that.
I think, thanks for addressing that. I think that, one of the things that that we know is that, for example, washing your hands is actually effective, but washing your hands appropriately is more effective than just a quick dash and drying. I mean, I like to say that you need to sing happy birthday to yourself twice while you're washing your hands. Don't do it out loud because people will think you're weird. But people just don't spend the time that they need to do it. And there are good ways and bad ways to wear a mask. I mean, we've all seen people with masks down to here and flimsy coverings on their face that they think is really doing a good job. So I do encourage people to look. The CDC actually has a nice website in which they talk about what masks are ideal and how to properly wear them. And so it's really best to know that and just inculcate that into the way that you, in fact, wear your masks. I wonder if you could address another concern that was brought up yesterday. Some people maintain that, quote, natural immunity is better against the Delta variant that's circulating right now than the vaccine. And this is really a dangerous idea. And I wonder if you could just talk about that a little bit.
Thanks. And I actually have a couple of slides that'll address that point specifically. So I'll try to bring those up here. And this is attributed to Shane Crotty, this first slide here. The immune system is quite complicated, and so it's not just one thing, and you cannot think about this in terms of a black and white, that it protects or doesn't protect. We know that the antibodies and neutralizing antibodies in particular are really the major part that's protecting against infection, but then protecting against all these other outcomes is really complicated. It involves CD4 cells, CD8 cells, memory B cells. And so a better way to think of it as not just black and white is that we have gradations of immune protection. Whether it's through vaccine-related immunity or whether it's through natural immunity, antibody levels and T cells and B cells and the location of the antibodies and the functionality, whether they're really good ones or not, are all very important. So this is really complicated, and the outcomes give us sort of different levels of immunity. Now, a cautionary tale with respect to natural immunity comes directly from this outbreak that happened in Brazil. And what happened here, I'll walk through very quickly. So these red lines here are the COVID hospitalizations, and the blue lines are the excess deaths. And you can see that in April, May of 2020, they had a outbreak sweep through the town of Manaus in the Amazon region of Brazil. And a survey was done, and actually 76% of the population was seen to have antibodies. So you'd think that's almost essentially at herd immunity, and that community should be protected. Well, not soon after, in December or so, a new variant came into town and completely wiped out the town again. So the natural immunity did not affect at all, or did not help the people of Brazil. Now, vaccine-related immunity, we've seen many studies like this one that do show there are different levels of protection to different variants, but generally they're all pretty good. So this is a study with the Pfizer vaccine, 2 doses, showing that you have pretty good protection against all these different variants. 1 dose, not so much, with those 1 dose giving you sort of the lower numbers there. And then I want to turn to actual clinical and epidemiological data with respect to natural immunity and reinfection. And this comes from Oklahoma. First of all, they're tracking their breakthrough cases in great detail, which I would love to see in other places here. But in terms of the different vaccines here, you can see breakthrough infections are occurring. You can see these numbers here: 1,000 for Johnson & Johnson, 3,000 for Moderna, and 5,000 for Pfizer. But the hospitalizations and deaths are really quite low. So yes, we're having breakthrough infections, but the protection from hospitalization and death is still very good. And overall, we're looking at a breakthrough infection rate of 0.5% of those that are vaccinated in Oklahoma, hospitalization rate of 0.03%, and a death rate of 0.006% in those that have been vaccinated. Now, moving on to, we've seen this in all different places throughout the country, unvaccinated versus fully vaccinated cases. And this is going from February all the way through September. You can see at the bottom right here, the percentage of cases in those that are vaccinated is quite low, 6%, 93% in those that are unvaccinated. So an 18-fold higher risk of being infected with COVID-19 if you're unvaccinated. But what about natural immunity? What about those that have already had COVID? Well, they're looking at this too. And this is the most fascinating part here. They're tracking reinfections. And you can see the reinfection cases defined as an infection that occurred more than 90 days from a previous infection. So the reinfection rate here per 100,000 from May all the way through September goes from this is a cumulative rate, 358 all the way to 1,000. And the breakthrough infection rate is over here. That goes from 37 all the way to 557. So what we're actually seeing is natural immunity not working as well as vaccine-related immunity. And in fact, it's twice as common to get a reinfection after being naturally infected than from those who are vaccinated. So I think this is the best evidence we have so far that natural immunity is probably not as good as vaccine-mediated immunity. And I'll just say in closing that when somebody has COVID-19, their immune system is in chaos. It's actually why people die of COVID-19, is the immune response being completely dysregulated. It's why steroids and immunomodulators actually work in sick hospitalized patients who are in the ICU. The immune system is not in very good shape during a acute COVID infection, whereas during a vaccine, it's a totally different environment. Things are controlled. You're giving a controlled dose, a controlled booster in many cases, and the vaccine response is likely much better than natural immunity. And finally, I'll say that natural immunity didn't help the people that died of COVID much. So on the first pass through, we have 1 to 2% of people actually dying of their COVID, another 30% getting long COVID, and natural immunity really doesn't help those people. So while it is a good point that in other diseases such as varicella and hepatitis B, we accept evidence of immunity, for example, for a work-related or occupational thing, we just don't know enough about that in COVID yet, and it does look like vaccine-mediated immunity is much better than natural immunity.
Yeah, thanks for that. I mean, I think it really does drive home 2 points. One is if you're dead, you can't get reinfected. That's just a kind of an obvious point, but really needs to be made. And the other is that there was a reference made in yesterday's board meeting about an Israeli study that looked at individuals with natural immunity having less likely a breakthrough than those who were immunized. But what was failed to be mentioned was that the group that had the best immune system response, or that had the lowest breakthrough rate, were those that had natural immunity and were then vaccinated. So it's really that study was actually evidence that vaccination after a breakthrough is actually a good thing.
Yeah, and I'll just comment that, I mentioned it's chaos when somebody is first infected with COVID-19, and some people do develop reasonable responses, but many people don't, and it is very highly variable. And so we can't take that as good protection. You're right that a vaccine, even a single dose of vaccine, gives people much, much higher levels of protection in what's called hybrid immunity.
You did mention something about therapy, and I know you answer questions a lot for clinicians across the country about therapy, and maybe I can just have you address a couple of those. The first is that some people think that since there are some therapies that exist, such as monoclonal antibodies, that you don't have to get a vaccine. I wonder if you could just address that.
Yeah, sure. I mean, I'm a big advocate for monoclonal antibodies. They certainly work, but they're not perfect. We think that they reduce the risk of hospitalization by about 70 to 80%, but we don't have any information about long COVID. And there are certainly still people that get monoclonal antibodies that still end up going to the hospital and dying. And we've had a couple of those in our own clinic. So it's not perfect. And is much better to have that protection before you get sick. That's the whole point of having an immune response. Essentially, by giving a monoclonal antibody, we're chasing that response and giving it to people to try to just keep them from getting sicker. Also, monoclonals, it's a lot of work. It's a couple of $1,000s. The taxpayers have paid for this. It's a whole clinic space. It's a lot of staffing. And most people that come in for monoclonals are now unvaccinated, which we could have prevented that infection with a $20 vaccine. Finally, monoclonals are temporary. They give you protection and they give you what's called passive immunity that really just goes away in 90 days when those monoclonal antibodies go away. Whereas a vaccine certainly gives you much longer protection than that.
We're coming close to the end of the hour, and I see that Dr. Gyamfi has to leave to take care of some patients. I know that others might need to do so. I wanted to thank those of you who were participating on this just while you're still here, Dr. Gyamfi. So I really do appreciate what you have. I'm going to ask Dr. Ramers if you have a couple more minutes, just a couple more therapy questions. But again, thank you all for participating in this. So yeah, so thank you. Some people think that that vitamin D is useful in the treatment or prevention of COVID-19. I wonder if you could address that, because that was specifically brought up yesterday.
Yeah, there have been some observations that people who are deficient in vitamin D may have a harder time with COVID-19. And so the idea is like, well, if we give vitamin D as a therapy, maybe that'll improve things. And there is a randomized controlled trial doing just that, giving half the people vitamin D, half the people placebo, and there was zero difference in length of hospitalization, in preventing mechanical ventilation, and in death. So it is a good idea to generally have good vitamin D levels. Being deficient in vitamin D may set you up for having a hard time. So go ahead and take your vitamin D, that's fine, and make sure your levels are okay, but it is not useful as a therapy for people already sick with COVID-19.
Yeah, thanks. And another one that was brought up yesterday was ivermectin. I think the claim is that we're ignoring evidence that it's inexpensive and then it works because people aren't making money off of it. But really, what is the true story about whether ivermectin is useful in COVID?
Yeah, certainly not ignoring the evidence. The National Institutes of Health, the Infectious Disease Society of America have very large and extensive evidence reviews of all the studies that have been done. The problem is the evidence is of very poor quality. There are some studies that show absolutely no effect at all of ivermectin, some studies that show us a mild effect, but in some, the evidence is not strong enough to recommend this. And in fact, some of the studies that showed the biggest effect were found to be fraudulent and have been retracted by the journals that originally published them. There are high quality ivermectin studies ongoing, 2 of which I'm aware of, that should give us better quality evidence to actually answer the question. And it is true that there is, if you take ivermectin in vitro, you can show that it has some activity against SARS-CoV-2, the virus that causes COVID-19. The problem is that in order to achieve the concentrations that show that in the test tube, you would have to take 100 times the dose that is normally used in humans when we use ivermectin as an antiparasitic, for example. So to go from the test tube to actual humans is a big leap. We saw that it didn't work really with hydroxychloroquine, where hydroxychloroquine also showed some in vitro activity, and it just didn't work when you got it into humans. So the evidence is coming. There is just not enough evidence at this point to say that it does anything.
Yeah, thanks. You know, someone made the comment yesterday that ivermectin was listed on the NIH website as an approved antiviral, and that's just not true. You can go to the website now and check and see that that's not the case. You mentioned chloroquine and hydroxychloroquine, you know, with or without azithromycin. Is there anything that, unfortunately, that is still being used by some people in the community? I know that you've told the story of people coming to your clinic who've gotten COVID, who are queued up to get monoclonal antibodies, and you ask them what they're doing and they're taking those. And I wonder if you could make a comment about the lack of usefulness of that particular combination.
Sure. Azithromycin, hydroxychloroquine have been really shown over and over and over again to not really do much at all. And it's just, I can see where it came from. It came from some early French data that was probably flawed, as well as some of the in vitro studies that looked good and promising. But when you go from a test tube to a human being, it's a completely different situation. And it's been actually scientifically worked out why hydroxychloroquine doesn't work in a human being. It has to do with some of the receptors that are in the airways that aren't necessarily in the in vitro studies.
Thanks. And I'm going to give one last question. I'll let you start. And I don't know if Dr. Sawyer might be able to leap in. You know, some people just really don't understand how mRNA vaccines work. I mean, they think that it's genetic manipulation, or that your genes are changing, or there's gene therapy. I just wonder if you could talk about just how the mRNA vaccines work to help really clarify things.
I'll start, and then Dr. Sawyer can hit clean up for me. So, you know, mRNA is a molecule we're familiar with from high school biology courses that really exists in the cytoplasm. These vaccines very delicately insert a small amount of mRNA, which is really gone within a short period of time. mRNA is very fragile, and it translates into proteins, and then that's it. It really never enters the nucleus, which is where our DNA really exists. I think of it as a Snapchat message, or just a delivery mechanism where the vaccine's there and then it's gone. And it's really an ingenious development, which we're going to probably use for many, many other vaccines in the future, such as a vaccine work against HIV and influenza and other things. It does not alter your DNA in the nucleus.
I'll just add in that it's a very specific and pure way of delivering a vaccine. We have some very crude vaccines that we've used over the years that that are sort of gmished up whole organisms that cause all kinds of side effects. So I think this is the future of vaccines, to target exactly what we need to target and not expose the immune system to other things that aren't important in protecting you against disease. They can be adjusted very quickly. So if we need a new version of COVID vaccines, a version 2.0, the RNA vaccines are going to allow us to do that quickly. So I'll say one more time that we've given over 200 million people these vaccines. So we know what the side effects are.
I'm going to just ask maybe one quick round robin, then that's it. Is there something that we haven't covered? There were some questions that we'll follow up with on our webpage that we didn't get time here to, but is there, if you had one, misconception that you wanted to address and could do that in a short soundbite, what would you like that last message to be here on this call? I'll start with Dr. Sawyer.
I'm going to go with what I just said. People who say the vaccine hasn't been studied enough are just not paying attention to the fact that we have studied it in millions and millions and millions of people, much more than any other vaccine we have ever used.
And Dr. Ramers?
Yeah, I just would like to emphasize that we are very good at hiding our suffering in quiet places in the hospital. And this is a very, very bad disease. Watching people die of COVID is terrible. Watching young, healthy people die of COVID is terrible. And watching people suffer from the long-term consequences of COVID is just frustrating and awful. I mean, this is just devastating to people's lives. So the initial narrative that this is just a flu, some people for sure, they will have mild illness. But so many people are now filling our hospitals and our clinics with these long-term symptoms that are just devastating.
Yeah, thanks for that. And Dr. Bakhtar, any last words from you?
Yeah, I'd just like to touch on this idea that some people have that this is all some sort of a conspiracy. And we touched on this earlier, the notion that me and the colleagues on this call, our family members and colleagues in other cities and colleagues in other counties and states and countries all are part of some conspiracy and are on the phone constantly hiding this from the rest of the world is completely irrational. It just makes no sense. We need to start listening to science. We need to start listening to the same people that we listen to when we're ill and are happy to listen to when we're ill. And get back to how we've always practiced things in modern civilization, which is science-backed and with respect of people who have made careers out of doing these sorts of things.
Wow, well, thank you very much. I really deeply appreciate the time that you've spent here, really away from the patients that you just referenced. And again, I wish you well for the rest of today. And thanks for participating in this session.